so let's start talking about a little bit of thyroid disorders. Okay, first off, let's talk about enlargements of the thyroid. And we could have basically one or two different enlargements. We have something called thyromegaly, and again, thyro means thyroid, megaly, as we saw with acromegaly, megaly means enlargement. Okay, so thyromegaly is a mild to moderate enlargement. Okay, and it happens fairly quickly, over weeks to months. But then we can have something called a goiter, and a goiter is also an enlargement, but it's over a period of like months to a year to a year and a half. It's very slow and chronic. Okay? Now, I want you also to understand that whether you have an enlargement there or not, an enlargement of the thyroid does not mean that it's going to produce a lot of hormone or very little hormone, T3 and T4. So you can have a goiter or thyromegaly, and it's going to produce a normal amount of T3 and T4. We call that euthyroid. All right, euthyroid is EU thyroid, as opposed to hyperthyroid or hypothyroid. So euthyroid is hopefully you and I are just producing a normal amount of T3 and T4. Okay. So we could have etiologies of these enlargements. Now, one of the easiest ones to deal with is something called a simple goiter. Now, we usually see something like this in terms of an endemic area. We sometimes refer to this as an endemic goiter. An example of this is this. Before I get it, when we do T3 and T4, right, we talked about T3 and T4. What is the 3 and 4 in reference to? Because we also have T1 and T2. So what does those numbers mean? Well, it tells you how many iodine ions are attached to that. Okay? So there's 3 versus 4 on there. So what I'm trying to emphasize to you is that you need iodine to make T3 and T4. If you don't have iodine, you're not going to make T3 and T4, and you're not going to be able to deal with metabolism. So in a case like this, and we see this in a good example is, let's go back to the Amish. Okay, the Amish lifestyle. That's back in the, Pennsylvania. They have a group of people, these Amish people, who they kind of do their own thing old-fashioned way. They don't use electric as much. Any kinds of foods they eat, they make. They build their own houses from logs or whatever. They don't use cars. They use a horse and buggy. But they do their own thing like that, and they do well. They do well. But here's a situation where you notice that they, let's say you go to the Amish county or the Amish town, and you notice that maybe 400 of them have these big goiters. What's going on? Do they have some kind of disease? Well, what's happening is, and I'm giving you this as an example, they're eating the foods that they actually grew. But for that season, the iodine was not in the soil as well as it was for the previous years. So now they're eating all this food that doesn't have high in iodine. So now as they're doing this, they're eating it, and they're not getting the iodine in their bodies. So what does the thyroid do? It compensates. It says, whoa, I need iodine. So what is it going to do? It's going to enlarge, make more receptors for iodine to come in. It's making a bigger net. It's realizing that if you don't have iodine, maybe iodine can't see where the thyroid is, so let's make it bigger so that you can actually see it, right? So this is a reaction because of low iodine. It's making a bigger net to grab whatever iodine's out there. How you fix it? Add iodine to their diet, and all of a sudden you see their thyroid shrink, okay? So that's an easy one to fix. We call that a simple or an endemic goiter, also non-toxic, okay? Then we have an adenoma or nodule. And what that is if you have this thyroid, okay, and we can have a nodule there. Sometimes that can produce a lot more T3 and T4. You can have, so that's one nodule, okay, or adenoma, maybe it's a certain part of this that kind of grows out. So a certain part of it, like a tumor like that growing. Or you could have many nodules. And when you have many nodules all around here, we call it multi-nodule. That what's happening here is that overall this thyroid has become bigger because there's more nodules there, a multinodular goiter. All right, so that's what they're talking about in terms of that. Okay. Then we could also have autoimmune diseases. You have Graves' disease or Hashimoto's. These are autoimmune diseases. Now, if we have our tumor here, or let's say our thyroid rather, and we have TSH, and TSH, well, the receptor for the TSH is going to be here. And the TSH will look like this. Okay? This part is going to go into here, perfect, like a lock and key, and that's going to make T3 come out and T4 to come out. Right? Not too bad. Well, what if we had an autoimmune disease where Graves' disease is going to make an antibody that looks like this, but it has a part that sticks out like that. Now that part fits perfectly in there. And what this is going to do is that that's going to fit in there and turn it on. It's like an imposter. It's going to turn it on, and it's going to spit out tons and tons of T3 and T4. Now, like I talked to you about with negative feedback, if you have a lot of T3 and T4, that's going to send a message back up to your anterior pituitary and hypothalamus to say, we don't need any more TRH and TSH. Stop making that come down. We don't need any more. But that doesn't matter because this is what's attached here, not TSH. So this is going to stay there, and this is going to pour out with tons of T3 and T4, ignoring whatever is up above. You see what's going on there? All right? Then we have Hashimoto's. All right? Which is also an autoimmune disease that kind of looks like this. That too can fit into here. However, as opposed to what Graves' disease goes in here and turns it on, this binds in there and turns it off. So it's actually plugging into a hole here and blocking any TSH from getting into there. So we can have autoimmune diseases that turn on things, and we can have autoimmune diseases that turn off things. We'll talk more about Graves' disease and Hashimoto's later, but that's what's happening with that. Okay? So does that make sense here? Okay? All right, so these are goiters. Okay? You see one over here. Some of them could be subtle. There's there. You see a fullness in the neck. Some of them are obvious. All right? Pretty big. Okay? So if you have too much of T3 and T4, T3 and T4. Females have it more than males, okay? It does not affect calcitonin. Remember, calcitonin comes out of the thyroid too, but for some reason it doesn't affect this. All right? We call it thyrotoxicosis when you have an extreme amount of T3 and T4. We have three different forms of it. We can have primary hyperthyroidism, which again means the source is at the thyroid level. That this is going to produce a bunch of T3 and T4. Something's caused, this is, whether it's a tumor here or Graves' disease, something is making this come out. If the source is at the primary source is at the gland itself. We call it primary hyperthyroidism. Then you have secondary hyperthyroidism. Maybe there's something going on up here, where you have the anterior pituitary and posterior pituitary, but there is a hormone that comes out of here, and this is your TSH. Maybe up here, there's a big tumor here, and that's producing a lot more of this. You see? So the issue isn't the primary source, it's the secondary source that's making this go on. Okay? Then we have what we call iatrogenic hyperthyroidism. Now, let's go back. What does iatrogenic mean? Yes, or treatment. In other words, iatrogenic means that there's some medical cause of it, probably due to the treatment. So here you have a patient that takes an exorbitant amount of synthetic T3 and T4 medication called Synthroid. So they're taking too much of it. So the source isn't coming from here, it's coming from some exogenous place, but they're coming in from their mouth. And that's going to give you hyperthyroidism symptoms. Okay? So if you increase the T3 and T4, if you understand the function, you're going to increase metabolism. So you're going to have a few things going on. You may or may not have a goiter. Most likely you will, or some sort of thyroidmegaly. Your hand's going to tremor because everything is going to go up, hyper. Your metabolism, you are going to lose a lot of weight. Sometimes I wish I had that, right? But you're going to lose a lot of weight because your metabolism increases. You're going to be sweating a lot. You're going to produce a lot of heat. So here's these people that have heat intolerance. It's 40 degrees out there. I know, but I'm sweating here. They can't deal with their body heat that's being produced there. You get irritability. Like, I don't know, I just bothered me. Just very hyper, that kind of thing. Anxious, right? And then you also have other things like tachycardia. What does that mean? Tachycardia. Well, this is about the heart. Cardia means heart rate. Tachy, like fast. Right, so that's fast heart rate. All right? So they have tachycardia, fast heart rate, because the metabolism is going very fast. They get palpitations. Palpitations, you actually could feel your own heartbeat without even touching it. It's like, whoa, I feel it. So you ask them, do you feel palpitations? They won't know what that is. So you ask them, do you feel your own heartbeat? Oh yeah, all the time. That's what that is. Restlessness. I can't sit down. I got to do something. I got to be, you have all this metabolism, all this energy. Diarrhea. Why? Why did you get diarrhea? No. What's happening with diarrhea is that you have muscles that are all around your large intestines. Large intestines are going to absorb water. Well, if you have a lot of energy, then these muscles are going to be squeezing those and all the food and everything that's in your intestines so much that there's no time for it to get reabsorbed into your bloodstream that it passes out, as opposed to sluggishly moving, right? So everything is like hyper. It's going more and more, okay? But that's what I'm saying. If you understand what T3 and T4 are, these things, it's not so much you got to memorize them. Just put together AMP1 and 2 with stuff that's over here. It's not all that hard, right? Now, let's talk about a specific type of hyperthyroidism, okay? So 75% of cases of thyrotoxicosis is Graves' disease. More women have this than men. This is an autoimmune disease. So let me explain to you what's going on here. You normally have this thyroid, and there is a receptor here that TSH is able to go in there. when TSH comes out of the anterior pituitary, it's going to go into this like a locking or a key and keyhole, right? It's going to fit right in there, and when it does, it's going to spit out T3 and T4. Okay? Just regular A and P 2 stuff. Now, what is Graves' disease? Well, Graves' disease is going to be something that looks like TSH. Well, that doesn't, but this does. This is Graves' disease. Your body is making antibodies, autoantibodies, that at least part of it's going to look exactly like TSH. And it's going to fit there like a lock and key. When this goes in there, this is going to really spit out a lot of T3 and T4. So this is an autoimmune antibody that turns on the thyroid. It's an imposter that is going to do that. Does that make sense? Okay? So that's what's going on with this. And we'll talk a little bit more, too, when we deal with thyroid function tests. So this is going to make a lot of T3 and T4 come out. Now, they get all the regular hyperthyroidism side effects that I just talked to you about, all those symptoms, tachycardia and stuff, but they also get a few other symptoms and signs that are more geared just towards the Graves' disease. One of them is that they get a diffuse toxic goiter. They get a goiter that's it's not going to be one little nodule. The whole thing enlarges. Okay? The other thing is that you get this exophthalmos or proptosis. This is what you were saying. The eyeballs kind of pop out. Now, we don't know exactly why this happens. We know what happens, but we don't know why. Our understanding of this is that there's so many of these autoantibodies, for some reason, they coalesce behind the eyeballs. Don't know why. And they start building and building and building, and it pushes the eyeballs forward. And they get these staring looks. I'll show you pictures of that. Okay? They also get this thing called pretibial myxedema. Again, not too sure why it happens. But really, they get this on their shins. Okay, so the front part of their tibia. That's why they call it pretibial. It's in front of the tibia. The skin gets very coarse, edematous, thick. I'll show you what that kind of looks like. So this is that Graves' disease. They get that stared look. Now, what it is about the stared look that's making it look stared is that if you look at each other, you do have sclera, the white underneath the iris. Everyone has it under, just resting your eyes, and you can see that. But you don't see sclera above the iris. If you do, that's the scared look, right? That's what's happening here. So it's the eyeballs being pushed out. So you can look at this. These are all other symptoms of hyperthyroidism. But the eyeballs, they get pushed out. And some of them get it's really severe. You could actually, the eyeballs, I've seen an eyeball actually pop out, and they got to push it right back in. Okay? So it's still attached. It doesn't come out and fall on the floor. But yeah, it's pretty, it's pretty bad. So this is post-tibial myxedema. This is not the same thing as what I just showed you, pre-tibial myxedema. Post-tibial, I couldn't find a good picture of pre-tibial myxedema. It's there, I saw them on there, but they were just very subtle. So I wanted to get something where I could illustrate to you guys what it looks like. And this is what it would look like if it's severe, but it's not this. You think of this on the shins, though. It's very dry and edematous and thickened, and that's what pre-tibial myxedema would look like. Okay, and you guys ever watched the movie Young Frankenstein? Right? Is it Igor? No, it's Igor. Right? Yeah, exactly. But this is an actor. He died now, but actor, I guess, in the 60s and 70s, who had Graves' disease. You can see that's a pretty prominent one, right? A smarty fellow.